So one foot support, one side support. I want to have the foot support at the end of the table because I want to stand here and do the surgery, basically. I'm also considering my position and the fact that I have to do this all day long. But I think everybody does that, right? Allez, c'est parti. So for me, hamstrings, I just palpate them in the back. Okay, and I extend it. They're gonna be here, and I'll go pretty close to the tuberosity. For me, the reason is that the skin is thinner.
Only vertical incision?
I always do vertical because of the revision. I mean, for the polyposition. There it is. And then basically anterior bitis gracilis, lower semitendinosus, horizontal incision.
Okay. You catch them and you go up or down?
I will go directly down if everything works out well and if I have a good visual without the light. Right angle. Go inside the sartorius fascia. Okay. Go low. And then I'll try to identify the semitendinosus. Try to strip it and double check if I have it, because it's not always easy without the light.
You cut the vincula? No, you
No,
open the sartorius.
Yeah, I just identify the tendon. Second part. And I will, in this case, and this is, I think, very important, I will try to lengthen it as much as possible. This is another centimeter. That's why I tend to do it more towards the okay. Suture. Good. So we keep the needle on there. Release. Okay, perfect. Okay, on this side. Nice. And this is now vincula on this side. Merci. Voilà. One. Tom. No. Cool. And and I pull trouble towards me. I'm not going to look for trouble. I pull it towards me. Okay, up. So this is one. Cocker on top of it. Double safety.
Double safety because you already had any problem?
Yeah, no, just it's culture.
Just you want double safety.
Yeah. Double Dutch.
So the choice is a very high lateral one,
Yeah.
and the other one is lower.
Is low and a little bit bigger, and aesthetically in line with the.
Okay, could you put your finger just on the anterolateral and on anteromedial? The portal you've already done.
Ah.
Yeah. Okay. Perfect.
Okay. Good. I'm going to take additional pictures, confirm the diagnosis. This is a high avulsion, but there you see the injection. Feels good. And there's no, we told you, on the MRI, I think if you have a good radiology department, you might, but I'll check it anyway. We go mid-flexion.
You check for the rump every time?
In general, I do. I might have some issues once in a while getting in between, and if it's a smaller lady, I mean, I'm not. There we go. This looks already good. I'm pretty low. Yeah, ça c'est bien. So no suspicion here. Okay. Look.
But you can create a lesion if you want.
Yeah. Yeah. Lateral side. There was a suspicion for just a lateral tiny lesion. Okay, I'll take this. For this lady, I'll take it. So this is a 7.5. Quadruple semitendinosis. Some stump preservation. But I'm not going to make my life difficult. So I want to see the femoral side clearly. We'll do some tibial stump. Toppie, duikbijtje. Stop, stop.
How do you choose the angulation for the tibia?
So routine, it's going to be 55. I change it if for my BTBs if necessary, like in the previous case, where we took it up to 60 degrees because the tendon was pretty long. And you want to have that tibial tunnel in line with Blumensatz, the roof of the trochlea. Go. You see intermeniscus ligament. We kept this nicely. Stump. If this is there, and
This is your position for the tibia.
well, for visualization, yes, because the alpha fat pad will recline. I have a better view on the insertion, but once we go into the drilling. So now we put the system in. Elbow aimer points our lateral meniscus. Follow it, and I put this one just behind at the level of that meniscus. There, up. I go into full flexion. You see that medial meniscus is now covering. Go. Tu prends. Voilà. So we measure the length, which is here, 35.
Where do you measure the length?
Here on the outside.
Okay.
Hugo, c'est mieux que tu fasses ça. Hein?
Ok. Tu vas donner
Mais tu te fais petit. Stop.
So you control the extension right now?
And I'll check my position. Okay, this is good. We'll do progressive drilling.
You start 5?
This is a 6 and then a 7.5 in her case. With the anterior horn of the meniscus here, it can really trouble your mind on the position, so you need to be conscious of that.
Clearly. Clearly. You have to think about several points, because if you just choose one, sometimes it's
Tu
troubling.
fais le premier cortex, tu attends. Et on repose. 7.5. Stop. A little bit more posterior. Super. Vas-y. Quand tu es là, top. Tu enlèves le pins aussi. Voilà. This is the graft. Okay. And then I'll check again. Boom. Nice. Go.
For the femur, you will stay in that position, or you will go in full flexion?
I go full flexion once we
First of all, you
identify
check.
the point.
First of all, you go with the point.
Yeah. Until we have it perfect. I think it's gonna be this one then. Is dat Greg die bent? Of wat?
Nee.
Ah.
Hij is bijvoorbeeld met de begrafenis bezig.
Het is dat ik dacht. Okay. Let's check.
Meter.
Now we go back. So plication there, cartilage edge. Plication, cartilage edge. That's gonna be perfect.
The mark in the graph is 15 millimeters in 20?
No, you can say it, yeah. So we mark the grafts.
Be sure that
We come in with a spade tip, flexion. This is also important. I mean, we measured it, we marked it, but I don't want to have any conflict with my PCL. So this is my third reference point. Here is that it needs to be in deep flexion and anterior to my PCL, somewhere in the middle of this imaginary triangle. Okay, so we now start.
So it means that if here if there is a conflict with PCL, you will change your position.
Yeah. And sometimes in big knees, it can make a difference. Again, the whole thing is designed for efficiency, so this is your finish line almost. Stick er maar in. Yeah, good. So this is about to finish. This is then 30. Boom. We pass it. We measure immediately. Tunnel of 35. Okay. 7.5. So the fact that it's close to the patellar tendon makes it away from the medial condyle.
This is the direct size. It's 7.5 right now.
Yes, 7.5. Up.
The length is 20.
So we're going to do 20. Where is this tunnel? There. So we're going to do 20. 20
What do you
there.
put inside? It's the shaver? Okay.
Yeah, it's a cannula. So 20.
Just something cannulated.
35, hè? Be careful. Compress. Loopy. Okay. This one for 7.5 is just a little bit too aggressive. Tunnel position. Geef me een duw. Okay. Pull. Gentle, hè? Pull. Pull. Ja, laat los, laat los. En haar hem gaan. Lange bek hier. Oui, et tu fais, non, tu nous aides à bien voir si tout passe bien. Stop. Tukbijtje. Parce que voilà. Okay, perfect. Yeah, so very important is that we keep counter traction there. I have full visualization, and we go slow now. So
could you just show us the suture, the number? Could you differentiate them? There is how many sutures do you have? 3, 4?
We have 2
Okay.
traction sutures, and then just the one.
What is the traction suture?
This is just for flipping the button.
This one is
This is flipping the button. This is for shortening the loop.
Okay.
Okay, there we go. So first of all, Sutkin will introduce the button. There's the button. Go. So I can follow the button now visually. And important, the graft is still not in there. Okay. So, and Sutkin marked also. Go.
So you can feel that the button.
Yeah, she's gonna now. Up. Double check here with the blue color. I don't see the button there. So counter pull. Excellent. And now we just start shortening whole process. And now and only now the graft will be introduced. Yeah.
So first of all the button and then after the graft.
Yeah.
Sequentially.
Sequentially.
It's really easier.
There's the graft. Okay. Perfect. Stop. Vertebral head, Gerdy's tubercle, lateral epicondyle. Okay. It's easy if you keep it. If you keep just your. This is it. Landmark. So I'll go around the epicondyle. I'm going to make it just a little bit bigger so we have a nice visualization. Curvilinear. That means that if you extend, it's going to be straight. Okay. And not to the sides. We open it up. Wait, I start. We do this identification and we cut just in the window, 1 centimeter anterior to this.
This is the
Yeah.
posterior border. And
posterior border and then the anterior border, depending on the size of the patient. Oh, no. Okay.
And what about the length? How do you decide?
The length is, I'm gonna take,
As long as you can.
no, it's gonna be about 10 to 15 centimeters. So Langenbeck. Again, this depends on the size of the patient. Make sure that they see. Perfect. All done. So posterior side. Okay. Pas trop, pardon. And once I start seeing the vastus, I'll go 5 centimeters basically. Vastus is there. Okay. So I'll go a little bit more up. Make it rather too long than too short. Too short is a pity. Okay, we pick it up. And we release. A little bit more posterior. So, okay. And there you have some connections, but basically strip comes out. Okay. ITB, and then we go down. I'm going to make a switch here. Gerdy, somebody. Okay, this is Gerdy. Don't pull too hard. Don't pull too hard. Okay. So you don't want to go anterior to Gerdy. Okay.
You go onto the Gerdy.
Well, I go to Gerdy. So that's what she's identifying, but the tendon will take me in that direction if I just push it. So I have to cut it. So this is the graft. And then, pak een keer.
So now you would find the LCL.
Yeah, LCL is now the most difficult bit to find. Cool. You feel, and it's. I can feel it, and I can imagine that it's somewhere here. So what I'll do is
we can see it also.
Yeah, you can see it, but not clearly. So I'll do this. I'll pick up the tissue, and this trick saves your life. From there to there, you open it up, and suddenly there is the
Could you
lateral
just
collateral.
take the part, go anterior like that, open the space. Great.
Okay.
Great. And you see the
But you take it from distal to proximal, not from here to there. That doesn't work. We're going to all just work in this flow. So below, up. 1, 2, 3, 4, 5. You want to have
open
this.
the space.
You want to have this. Tom, is dat juist niet? Het is een beetje groter dan gebruik ik, nee?
Why did you change your position? Because you want...
Yeah, you want to have the tip of this instrument free, so it goes first and then the tendon follows. Okay, up, and then we flip it again. We go to the vastus, which of course has a different position in every patient. Sometimes you can have even some gastroc here.
Yeah.
Have to go in, up. Oh man.
Have you already had some hematomas on that?
That's why you put the drain in there. I had one hematoma with an international patient, and he lost 1 liter. I've never seen that. We always loosen up the tourniquet also before we close. I'm going to feel 2 things. First of all, I want to feel my button. It's there. Second of all, you want to feel the posterior side. You want to feel the posterior side of that iliotibial band. En, een keer kijken hier. Okay, c'est bon. So the button is there.
You can see, you can feel it, but you can't see.
I can show it to you if you want to. You see the button?
Yeah, we see the bottom.
Okay, here. Super. So I want to be proximal to the button, right? We don't want to have interference with the tunnel. No tunnel
Proximal
collision.
and posterior.
So we're going to go proximal, and you want to be just ahead, anterior to the Kaplan fibers, like 1 centimeter, but on the posterior half of the femur. En up, je voelen hier eerst. Ja, c'est bon, c'est bon. I mark. We chisel to open up the cortex.
Why? Do you think it increases?
Well, first of all, the introduction of a staple in that area is easier. You don't have issues. And second, you get some more bone marrow. Yes, exactly. So it's a little bit more controlled. I just go for like half a triangle. The corner of the up in there. You can open it up a little bit. You keep it. And then scissors from here. We go below all the fat. And I go straight up into this area. Okay? Straight line. Again, 5 times. And then we do the same trick. There. It pops up. Graft. Release. And in this case, now we shift for a bigger clamp to make sure we have a good hold on the graft, horizontally placed, and in that position which I marked there. I'm going to introduce it halfway. Halfway. And then we're going to do positioning of the knee. It's a female. She's not...
So external rotation, slight.
Yeah, depending again on the patient profile. She's a female, not big quads. I'm not going to over tighten this one. But this is important. So she's pulling and basically levering on the tibia. So the tibia is basically reduced by pulling and levering. This one, 2 kilos, and don't pull it outside, pull it inside. Okay? And then you just... Okay. Good, feels good. We can release. External rotate, but tightening. Okay, and then we're going to go to the tibial side, so this is good. And first of all, I'm going to check isometry. This is perfect. We cut the safety stitch and we start shortening. Okay. And then we tighten in the patient-specific position. So you want to have 20, 10, 0, depending on whatever choice you have, the isometry of the graft, the patient quad mechanism. For me, this is, again, I'm going to go do close to extension. I don't want her to end up with an extension loss because she has small quad. So we go here, I push the tibia down, and I shorten. Maximal pull. Just for safety. 1 suture. 2.
Is that mandatory or
No.
you want?
No, there's no slack. I just do this, and then we go in full extension, and then Sutkin's gonna just and tell us if there's still something there. Okay, good, done. We cut this one. So this is the graft. This is the footprint here. Okay, graft in the footprint, full extension. You just eliminate any inflammatory tissue. Copy. Perfect, almost like new. Nicer.